Alors, ça marche.
Renee, we are ready to go. So I hand over to our very able commissioners. Please get us started on day 3 of the AHAIC conference. Thank you.
Bienvenue à tous à la grande conférence AHAIC 2021, n'est-ce pas, sur la question, n'est-ce pas, de santé au Cameroun. Ce jour, nous allons faire l'introduction. Docteur Oniswa de Madagascar et moi-même, jeune poète du Cameroun, et ce sera avec un grand plaisir. Docteur Oniswa.
Bienvenue à tous à la dernière journée de la conférence internationale sur l'agenda pour la santé en Afrique 2021. Je m'appelle Dr Oniswa Rinjalde, responsable national pour Options Consultancy Services Limited à Madagascar et aussi commissaire de l'AHAIC.
Donc, et moi, comme je vous l'ai dit, je suis jeune foyette, conseiller en politique de santé publique et je travaille en ce moment avec la Convention baptiste camerounaise. Et nous avons le plaisir de vous accueillir en ce dernier jour de l'AHAIC 2021, le jour de faire le bilan, le jour des résolutions et le jour des points d'action.
Au cours des 2 derniers jours, plus de 3000 participants du monde entier ont participé à cette conférence. Alors que l'Afrique continue de faire face à la pandémie du Covid-19, nos conversations d'hier ont abordé des préoccupations essentielles concernant la sécurité sanitaire et la CSU en Afrique, y compris les mesures clés que les pays africains doivent prendre pour définir un avenir après la pandémie basé sur les principes de la santé pour tous.
Et donc, évidemment, le programme d'aujourd'hui portera sur l'équité et la redevabilité, qui sont des éléments, des piliers sous-jacents, n'est-ce pas, les plus importants dans le cadre de la couverture sanitaire universelle. Donc, pour un changement durable et en long terme, les institutions de santé, les gouvernements, les pays, n'est-ce pas, doivent s'engager à être redevables et à réorganiser tous les systèmes et politiques qui perpétuent les inégalités en matière de santé. Donc, les conversations d'aujourd'hui s'appuieront nécessairement sur les expériences des responsables de santé, des acteurs des droits de l'homme, n'est-ce pas, afin d'explorer les moyens par lesquels les pays africains peuvent promouvoir l'équité et la redevabilité en matière de santé. Donc, plusieurs sessions intéressantes sont prévues pour aujourd'hui. Donc, dans quelques minutes, nous commencerons le programme d'aujourd'hui par une séance plénière qui portera sur notre santé, nos droits, la CSU et la redevabilité pour tous. Nous avons également de nombreuses sessions parallèles intéressantes parmi lesquelles vous pouvez choisir. Donc, aujourd'hui, parmi les sessions parallèles, nous avons des sessions qui porteront sur les thématiques allant de la nutrition, des soins de santé primaires et du leadership des jeunes en matière de CSU. Des questions sur l'éducation sanitaire, la communication en matière de santé, les questions liées à l'innovation et les questions liées à l'actualité des réticences et notamment de l'adoption des vaccins. Donc, nous examinerons aujourd'hui également comment l'Afrique, notre merveilleux continent, peut faire face à la charge croissante des questions telles que le cancer, les maladies, n'est-ce pas, non transmissibles, les maladies rares, et donc qui doivent faire, n'est-ce pas, dialogue, partie, n'est-ce pas, des dialogues de la CSU au niveau du pays. Donc, et nécessairement les questions liées à l'hygiène et n'est-ce pas, à la salubrité, pour voir comment ces questions-là, n'est-ce pas, peuvent être également prises en compte dans la question de la couverture sanitaire universelle. Donc, il y aura une table ronde de haut niveau qui réunira les parties prenantes pour discuter, n'est-ce pas, des raisons pour lesquelles une agence africaine des médicaments est essentielle, par exemple, pour optimiser la durabilité de l'approvisionnement en produits médicaux en Afrique, et une session notamment sur les héritages en matière de santé mondiale, n'est-ce pas, qui examinerait un peu comment on peut décoloniser les partenariats mondiaux en matière de santé, ainsi que les pratiques, n'est-ce pas, d'aide et de financement. Donc, ces merveilleuses questions seront débattues aujourd'hui par les panels que nous aurons. Donc, à l'issue de ces sessions, nous espérons que vous nous rejoindrez tous pour la cérémonie de clôture au cours de laquelle nous discuterons des principaux résultats et des résolutions de la conférence et remettrons le prix AHAIC 2021 à 4 dirigeants africains, n'est-ce pas, pour leur remercier de leurs engagements exceptionnels dans le secteur de la santé en Afrique. Donc, voilà, chers membres de cette auguste audience, participants de la conférence, détailler sommairement les points qui seront abordés au cours des différentes sessions d'aujourd'hui.
Nous aimerions également vous communiquer quelques informations importantes. Veuillez accéder à toutes les sessions via l'auditorium sur la plateforme de la conférence. Vous trouverez le lien vers l'auditorium en haut à gauche de la plateforme de la conférence. Une fois chaque session terminée, veuillez retourner à l'auditorium pour sélectionner la session suivante. Il vous suffit de cliquer sur le lien « Rejoindre » qui apparaîtra une fois la session est en ligne. L'interprétation est disponible en français et en anglais. Pour accéder à l'interprétation, cliquez sur l'icône du globe terrestre en bas de l'écran une fois que vous êtes dans une session. Enfin, veuillez prendre un peu de temps aujourd'hui pour visiter la salle d'exposition. Ça va nous apprendre davantage sur nos partenaires et sur le travail accompli pour promouvoir la CSU en Afrique. Donc, avant de démarrer notre programme intéressant, j'aimerais vous présenter une courte vidéo de nos partenaires de l'UHC 2030 qui jettera les jalons des discussions plénières que nous allons suivre. La vidéo. Il n'y a pas de son. Sans plus tarder, alors...
Donc, nous avons des soucis techniques.
Oui,
je pense que l'homme a créé la technologie, mais il arrive parfois que la technologie nous donne soif. Donc, permettez-nous, donnez-nous encore quelques secondes pour relancer cette vidéo. Merci.
Today we know that people are anxious about their health, their finances, and their futures. Trust in some governments is eroding.
poor and marginalized communities are being pushed further behind. Frontline health workers desperately need your support. Too many decisions are being made without key stakeholders. Too many policies are gender blind.
But there is also hope. We urge all of you to take these actions with us.
Donc, sans plus tarder, veuillez nous rejoindre pour accueillir Renée Ngamo, présidente d'Amnesty International Kenya, qui sera la modératrice de la plénière d'aujourd'hui. Merci beaucoup.
Donc, Renée, vous avez la parole et merci, merveilleuse conférence.
Thank you very much indeed, and thank you for the video as well. You're right, technology is not infallible and neither are we, but this could be the conversation that makes a difference indeed. So thank you. Your Excellencies, distinguished guests, ladies and gentlemen, persons of all walks, all persuasions joining us today, Hamjambo. I greet you today and I welcome you to our session. My name is Renee Ngamo. I have the honor of serving as the chairperson of Amnesty International Kenya. And it is a great honor indeed, to share this platform with so many who are so concerned about the state of our health, especially at this time. I want to thank AMREF Health Kenya and the co-conveners of this conference, Africa CDC, African Union, Roche, Takeda, the International Federation of Pharmaceuticals, the International Federation of Pharmaceutical Manufacturers and Associations, and everyone else who has made this possible and has made this happen. Allow me to acknowledge our comrades who are here, who are French speaking, Excellences, distingués invités, mesdames, messieurs, personnes toutes horizons. Qui nous joint à nous aujourd'hui. Je vous salue aujourd'hui et vous souhaite la bonne venue à cette session. C'est un grand honneur de partager cette plateforme avec tant de personnes si préoccupées avec l'état de la santé, particulièrement en ce moment. Et maintenant, je vous demande à toute humilité de me permettre de continuer en anglais. We know now, more than ever, that the issues related to health are so intertwined that a sneeze in one part of the world can literally be the harbinger of a global pandemic. This could not be more obvious than the fact that today we meet virtually because of such a pandemic. Here on the continent, we've had our share of diseases, of epidemics, as it were, pandemics. Some are loud and wake people up to the need for urgent action. Polio, HIV/AIDS are just some of them. Some are silent and seem not to be worthy of universal and concerted, focused effort to eradicate in the way in which we have dealt with diseases like polio. In Kenya, where I'm from and where I have the honor of reaching out to you from, we continue to record the deaths of over 6,000 Kenyans annually from absolutely preventable causes. Their crime, in quotes, for which the judgment is death, they are women in areas, in places, in times, in moments where they are unable to access the very basic that is urgently needed for maternal health care. We lose them every year. And every year we speak of what we shall do better next year, and yet the deaths continue. The silent pandemics. We continue to lose children on this continent to hunger, to diseases and conditions that are brought about by malnutrition and other conditions which we can eradicate. And yet, in the same vein, we continue to celebrate our award-winning cash crops, roses from idyllic farms next to scenic landscapes, and coffee from cool highlands, tea from our richest soils, and see no link between these two. And that if we can produce award-winning, high-class, great value, organic horticulture to take away from our land using the labor of those mothers and those children who survived the first 5 years, then do we not owe them the same kind of nutrition? While many of our governments have ratified at least one human rights treaty, which requires them to guarantee the right to health, we continue to report the lack of access to affordable drugs, corruption scandals of eye-watering proportions in our government's health ministries and associated corporations, while our poorest and our most vulnerable continue to struggle to afford basic treatment for the most common and the most preventable illnesses. Basic things such as clean water that is from a dignified source near them. We hear of vaccines negotiated at almost double the prices, negotiated for richer and better-to-do nations than ours. And we are informed that the costs of availing vaccines to the continent are such that the doubling of the price is the best that we can do. Yes, I intend to provoke you in this conversation today. Our currencies now, many of them on the continent, severely hit by the economic effects of the global pandemic and of earlier financial slowdowns, now square up with expensive vaccines, and the payments will cost even more than they would have before because of this fluctuation in our currencies. The burden on our fledgling taxpayer base becoming even heavier, the costs of fuel, VAT, GST, and other taxes that are generalized becoming even higher so that we can pay for our health. Our own constitution in Kenya enshrines in Article 43(1) the right to, and it says, the highest attainable standard of health. And this includes the right to health care services, including reproductive health. And this is a fundamental right. And yet, as you have heard in earlier panels, if you had the privilege of joining this conference earlier, COVAX expects to provide 600 million doses, or about 20% of what is required on the continent that has the youngest, the most energetic population, with a possible 270 million other doses being acquired by the African Union initiative, barely starting what we need to do. I pose this question to you. Are we looking at a repeat of the deplorable situation that we saw in the 1990s at the start of the HIV/AIDS pandemic and the disparity between distribution and availability of the much needed antiretroviral virus kits, and medication on the continent that had the highest and the most virulent of cases, and where it took 6 years before the ARVs were fully available on the continent. Now we are at the cusp of another pandemic. Are we on the continent to wait 6 years before we are covered once again? You see, these stories are more than statistics. Allow me to speak with you directly. For those who have met me before, you know I do. As we speak in my own housing estate where I serve as the Residents Association chairperson, we are today raising funds for the funeral of a father who buried his son 2 weeks ago. This is the sixth death in that family in 5 months. Their matriarch having died caring for each one of them as they underwent the very terrible effects of the disease that we are now fighting globally. We know that women will continue to be those who will be caring more for the sick and therefore more exposed and therefore more likely to catch the worst effects of this pandemic. Last weekend, I was at an event where, as I was asked to begin to speak, I asked in the room of 54 people, how many people have lost a loved one since the pandemic began? Only 7 people did not raise their hands. Even the waiters had their hands up. As we begin this conversation, I reflect on a now famous saying in our country by a long deceased former vice president of Kenya, Professor George Saitoti, who said that there comes a time when a nation is much more important than an individual. There comes a time, comrades, when lives must be more important than profits, when humanity must be more important than narrowed interests, where the might of technology, of money, of modern equipment does not inadvertently lead to eugenics or indeed catastrophic deaths due to profit over people or due to the fear and the static refusal of men, women, people of good intent from moving from established protocols and creating something completely new so that we can deal with something that we have never seen before. Indeed, we are the generation that future generations will speak of, read of, study. What we choose to do now will echo into an eternity where one day what happened in this epoch in which we live will be the subject matter of study, will be an examination question in children's and indeed in high schools and universities where they are studying pandemics such as the Spanish flu once was, and will be the stuff of legend. The question is, how does the legend end? Our panel today is made up of eminent practitioners and I dare say leaders in their own field. So allow me to briefly introduce each of them. And as I introduce them, I will ask them to turn their cameras on as I speak of them so you may know of whom I speak. I know that you have seen the bios. Let me begin with Dr. Anastasia Thompson, medical practitioner, LGBTQIA health rights activist from South Africa. Welcome. Dr. Esther Njoroge, the advisory group member of the Civil Society Engagement Mechanism for the UHC 2030, the Vice President of Smile Train. Welcome. Dr. Suzanne Weisbacher, Global Head of Access to Medicines at Takeda Pharmaceutical International. Welcome. Ma Sarah Keita, who is the Director of Programs at the African Society for Laboratory Medicine. Welcome. And I'm quite sure, if not yet here, then will be shortly, Julian Lusenge, the co-founder and president of Female Solidarity for Integrated Peace and Development and the director of Congolese Women's Fund. Welcome. Our interpreter today is Felix Owino, and so I will ask kindly that even as our panelists speak, that we just remember that he has to assimilate and interpret this for our French speakers, so I'll ask you to be slow for, and indeed for our English speakers as well. We will go into plenary, into a panel session now, and I ask that any questions that you have, that you would put them in the Q&A, or indeed that you would put them in the chat and enable me to just see as many of them as I possibly can, and to be able to read them and to pose them to our panelists. Our closing remarks will be by the Honorable Ms. Mary Rose Winnie-Effa, who is the President of the African Parliamentary Forum on Population and Development, and whose greatness I shall speak of shortly. And so I shall introduce her in a while. For the speakers, and indeed for everyone, please keep your microphones on mute until it is your turn to speak, but remember to unmute so that we can all enjoy this conversation. For the chat, like I said, allow me to be able to follow you and to see exactly what it is that you're saying, and it's great to see so very many of you. So let us go directly into the conversation. So let me start with each of the panelists and ask you directly for each one of you the following question, which is the health right that you think is being neglected or left behind as countries are designing their universal healthcare systems? Which issue do you feel most inclined to champion for? I'm going to ask this first to Dr. Anastasia Thompson.
Thank you, Renee. I think it's an insightful question. I think it's a difficult question to answer because so many of the different challenges that we face are interconnected. I predominantly work in the field of LGBTQIA+ healthcare and access to systems that carry with them a legacy of colonialism and patriarchy and discrimination and prejudice. And I think that the reasons for that are manifold. I think that these systems are built on institutions of discrimination like racism, like sexism, like homophobia. I also think that there's inherently in all of this still the evil of medical paternalism, where we strip people of their agency. So I think that when you have a discussion about which rights are being left behind, to discuss minority rights or groups that are marginalized, the conversation always has to hinge around agency, autonomy, respect to identity, and it comes back to a platform of human rights where we still attribute value to certain people based on characteristics that should have no role in determining the worth of a human being, how loudly their voice is heard, or the kind of access that they get to healthcare and other basic services. So to look at someone and say, based on your gender, based on your sexuality, based on the color of your skin, your access will be limited. And I think that in a lot of ways, the challenge in navigating a pandemic like coronavirus and COVID-19 is that it almost shifts attention away from the plight of the marginalized, and it certainly worsens the situation that many of these communities find themselves in. So however difficult it was to get access to healthcare for a transgender patient or for a lesbian woman, this has been probably amplified by COVID. Maybe we have ramped up COVID testing, but we certainly have diverted resources away from marginalized groups. And I think it's really the voices and the agency of these groups that we need to fight for moving forward, because again, we can't identify the needs of a group unless we engage with them. We need to amplify those voices. And I think that's the fundamental point in trying to meet the needs and provide the services, is we need to hear the voices. So thank you for that question.
I love that you picked up on that, and I want to change the question slightly as I move to Dr. Esther Njoroge. The work on the Smile Train has been very much focused on rectifying, of course, the work that you do is really incredible. And yet, even though we've seen momentum around the universal healthcare coverage as the most predominant, or as the predominant health goal for African governments and development partners, it almost looks like vertical programs are being silenced, or they're being sidelined or deprioritized. What interventions can you see, or what do you see as an opening for policymakers, donors, and those like you who are on the ground working to rethink funding structures and to rethink operations in a way that can allow everyone to focus only on what is required as opposed to these parallel silos? Dr. Esther.
Thank you very much, Renee, and thank you for that question. Naturally, for me, I champion for surgical services, especially for children. As you rightly put it, we are focused on providing access to care for children born with cleft lip and palate, cleft lip being a gap on the upper lip, and cleft palate being the hole in the roof of the mouth. And these are conditions that a child is born with, what we call congenital malformations. And therefore, vertical programs, I must say, are here to stay for a longer time, because that's how organizations get so good at what they do, by being focused. However, the shift that we are seeing in light of universal health coverage, and I'll speak specifically about Smile Train, which is where I have the behind the curtains view, is that we are looking through that lens of our vertical program, being able to impact the entire health system and strengthen the health system. That our support is traversing not just the children born with cleft, because when we provide support for, say, infrastructure or for equipment or for training, it is not just for the child with cleft, it's for all children and adults who need surgical services in the country. And therefore, I see this as an opportunity for policymakers to slice up the cake that is universal health coverage. While the funds are in vertical programs, the government policymakers have the whole cake to look after. And therefore, those slices what make the whole cake. Being able to articulate what their universal health coverage looks like, because it's different for every country, and how it will pan out is different for every country. And being able to say, who are the stakeholders that can support us in actualizing what we need to achieve, and piece that to be able to marry the donor, the development partners, and the implementing organizations on ground. And together we deliver for the common Kenyan who should not be left behind, who should have access to safe and quality care, who should have qualified healthcare professionals taking care of their health, and who should be informed of how to prevent the preventable health conditions.
I love that you've spoken of cake and slicing up the cake, because a large slice of that cake, if I can continue with that analogy, includes the pharma companies and their critical role. And so this, to Dr. Suzanne, just zooming in on the fundamental shifts that need to happen in order to accelerate universal healthcare, to strengthen health systems, to withstand future threats. How do we align the oft battered commercial interests of pharmaceuticals and manufacturers with the social goals of universal access to drugs and medicines, particularly amongst those populations that do not constitute a profitable or a sizable market necessarily? And specifically, how has Takeda aligned its own strategy to meet the UHC goal?
Thanks so much, Renee, and thanks so much for having me here today. It's a very honor to talk to here with that great panel. So coming to your question, how can we align, and I very much like the cake analogy as well, like what is the slice that the pharma industry should contribute? And also staying in this analogy, I think it also quite nicely illustrates that it's not just one slice that makes the cake, but all slices together. So, which brings us to the entire partnership approach. Before going to that, so if we focus on the pharma industry and what did Takeda to actually, and Renee, you said it very nicely, when we zoom in on the fundamental shifts that need to happen. So we at Takeda, I think I'm very privileged being at this company because we believe, based on our values, that for rare and complex diseases and life-threatening diseases, we look for opportunities to provide access, even if there is no profitability case behind it. And so while we also then need to see and need to take into consideration what is the unmet patient need, what is the health system maturity levels also to grant outcomes, this is why we have the broader health system strengthening approach combined with providing access. And some of you might know the Blueprint project in Meru County in Kenya, where we bring in many different partners along cancer care to really drive access to health and drive impact. So I believe Renee, coming back to your question, I believe the openness to, while driving profit, to also broaden access, and very often we also try to broaden it sustainably, so quite not profitably, but at least covering some costs to a reasonable extent. And that, together with a commitment to address access barriers, to literally help health systems to evolve over time, so that we move together towards universal health coverage. Because also, if you imagine we have universal health coverage, but then the quality of the health services is not strong enough, then you still don't have the outcomes we all hope for all patients. So that's why I believe it's an important balance of providing access, strengthening the health system, and doing that in partnerships. And that's kind of like, for us, a big belief at Takeda, working with partners, because we feel we are more sustainable and driving more sustainable impact if we work together with on-the-ground partners. So it's not just us, Takeda, from somewhere supporting, but it's literally working with local experts, with local NGOs, with local other companies on driving impact and making sure that many people are involved, finding the balance of not too many, but many are involved to have an effective program and to also share the load. And that will then also help going forward to really drive consistently the advancement of health systems. So it's like one part, like in summary, is like, okay, there is a certain, I think, contribution also the pharma industry can bring to the table. And the other part is a strong belief in partnerships under the guidance of the government, so that we are also moving in a synchronized way against strategic goals of the local health system.
Indeed. Thank you, Dr. Suzanne. I think one of the things when we talk about strategic goals are local
Renee,
clinics or local healthcare, and this Masariketa. I beg your pardon?
I'm sorry, Renee, we couldn't hear your question. Could you say it again?
You were breaking off. Maybe you can repeat your question.
Oh, this to Masariketa, which is, let's talk about the pillars of affordable and accessible and equitable healthcare. Buy more equipment so that there's diagnostics. However, it's still either, far from universally accessible, and number two, far from accessible to those who need to access it when they need to. What opportunities, Masare, can you see, especially in low resource settings, where access to quality care is limited for the advancement of healthcare provision. And also, how do we hold governments and private leaders and indeed private organizations accountable to provide healthcare for all, especially those who have been left behind in the past, like the women of whom I spoke earlier. Masare.
Yes. Thank you so much for that question, and I'm very excited to be part of this panel. So we look to new technology and innovation that's affordable and cost-effective as ways to increase, to advance healthcare provision, including in low resource areas. There are things as in the diagnostics field, which is where I have expertise, we have been doing a lot of implementation of rapid tests, rapid diagnostic tests, so that we can at least reach out to communities that have been left behind. A lot of the advanced testing is performed in the capital cities, unfortunately. And because of poor transport systems in a lot of our countries, we don't have the sample referral systems, sample transport referral systems that can meet the demand and can meet the need and can reach patients in a timely manner. And so there's been a lot of a push for implementation of rapid tests or point of care tests. We have new technology in place that allows for more accurate and quick testing diagnostics. There's also been some innovation around the use of drone technology, for example, where they've used drones to do sample referrals. So bringing samples to further testing sites in a manner that's rapid and that takes into account the poor transportation systems that we have in a lot of our countries. So I really look to innovation as a way for us to really improve. And we have young, dynamic population that could come up with really good solutions, health solutions adapted to our local needs and adapted to the context. As far as how we can hold government and private leaders accountable, I think that one of the things that we haven't been doing so well with our health interventions is in terms of measuring, providing the data and reporting the data and reporting it publicly so that everybody's aware of whether progress is being made and progress or lack thereof. So I think we need to do better in terms of monitoring and evaluation, identifying indicators, and then making sure that we report publicly so that leaders are held accountable and they can be compared to other countries that are actually making significant advancements.
You know, different issues, Raul Mutai, UHC to become a reality, and also speaking of governance and leadership. And thank you so much to everyone speaking and giving a lot of feedback. I want to sort of circle back in a sense. We know that in very many situations, civil society, universal movement for health for all, and similar other movements. Dr. Esther, how, first of all, how has civil society adapted the way they operate to hold governments and private sector and development partners, as well as their own organizations, accountable to ensuring UHC principles are adhered to? And what can they do different or better so that they can be able to ensure that there is a delivery that works better, especially in this pandemic situation? Dr. Esther.
Thank you, Renee, for the two-in-one question, quite complex. And I will start with, I sit on the advisory group of the Civil Society Engagement Mechanism for UHC 2030, and the role of what we call CISEM for short, and the role is to raise civil society voices under the UHC 2030 multilateral platform, to ensure that the UHC policies being developed are inclusive, they are equitable, and that the civil society voice is being included. Here, civil society is not your usual, what civil society to be. It includes non-governmental organizations, community-based organizations, patient representatives. And in that space, one of the adaptations that have happened is together we come as one voice, regardless of the what you have called vertical programs that we are dealing with, and have a unified voice for universal health coverage. And just before, to the run-up to the high-level meeting, the UN high-level meeting in 2019, CSEM rallied civil society to contribute to the key asks that were being made under the political declaration. And when that declaration was signed, countries committed to important steps to take towards universal health coverage. And that conversation has carried forward in looking at how do we hold the governments accountable to the commitments they made? How do we hold ourselves accountable to what we are holding government accountable to? And the second adaptation that has been done is developing a social participation handbook, which is a practical guide, evidence-based to policymakers on how to effectively engage civil society, being those groups that I've talked about that are not government, in their policy making. Because as we know, a lot of policies, as the video that started this session showed, a lot of policies do not involve the voice of the citizen. They do not consider the wider consultation. And therefore, this handbook is aimed at supporting policymakers to effectively engage civil society. And how do we hold ourselves and organizations accountable is what Keita talked about. We need to identify the commitments made by our governments. We need to know them. Everybody on this call needs to know what your government signed up to. What are the metrics that we are measuring? Because it's a journey. How do we know whether we are heading in the right direction and whether we are getting there? What are we measuring them, and are we reporting them? And that is how we hold. And I want to tie this to a question that has been asked about how do we how do we ensure that there is accountability? Let us know what needs to be measured. Let us be measuring it, and let us be constantly be the pain in our government's side that you committed to it. What did you commit to? Because it's not a statement. There are specific steps. How are we getting there? And to give the example of Kenya, we have developed a policy that will guide the implementation of universal health coverage. In that policy, there are key priorities that have been outlined. And it's up to us, civil society, to follow through, because Kenya is well known for making excellent policies and never implementing them. It's up to us to hold government accountable to ensure that policy is implemented.
It's up to us. I hear you. Julian Lusenga, are you with us now? I'm just quickly checking. If not, then this question really should go then to Anna's. Which is this question of being heard. And the advocacy and the dialogue between civil society, policymakers, service providers has brought us now to this place where we can talk of UHC. Still know that continue to be marginalized or to be suppressed in one way or the other, she enumerated earlier. Challenge for us from where usage, in order for us to turn up the volume on those who have been marginalized. that their voice, it can be incorporated in policies, and they're turning a blind eye and hoping that UHC will be blind. Dr. Anastasia.
Renee, I'm going to have to ask you to repeat the question. I've had your feed breaking up a lot. I'm not sure if it was the same for our audience, but I know I didn't hear the question as clearly as I would have hoped.
The question is, how do we amplify the voices of those who continue not to have their voices heard and whose specific issues continue to be swept under the carpet of a quote unquote blind application of UHC? Your thumbs down. I know that internet can be very
It's fine.
Excellent.
I think I have your question. And I think, again, it is a very good question. You know, I think policy is such an important instrument, but I also think it has so many limitations. We've heard from one of our other speakers about how the governments in some countries are notable for crafting these inclusive, progressive policies and then not actioning them. And I know this is true for my setting in South Africa. I've heard that it's true now in other parts of the region. I think we often craft policy and we use the existence of the policy as an excuse not to do the rest of the work. And the rest of the work is a cultural and a social conversation. It is a discussion around why the policy is important, how it applies practically, what the experiences are of people who are marginalized. And I think there are many ways that this can be addressed, but one of the fundamental issues, and I'll come back to what I said earlier, which is to say that this is about human rights. And once we start to see this through a lens of human rights, we need to understand that what we're talking about here are not figures on a page, but these are the experiences, the very human experiences of so many groups. And there are aspects of commonality that we all share, that we are able to tap into. So I think so much of this lies in the actual narrative, the actual description of the stories, the life stories, and the experiences of people who have been disenfranchised. I think this is how you get society to take this seriously and to understand why the policy is important. Because if we institute a policy that speaks to the rights of women, or the rights of children, or the rights of queer people, we hear about it, we speak about it, we see it in the news, but we don't understand why this is important to us if we are not part of that community or those communities that are affected. And in so many cases, the decision-making bodies and the health institutions and the organizations and the ministries are run by people, steered by people who don't have the lived experience. We cannot understand someone else's lived experience. It belongs to them. But if we share those stories and we amplify the narrative itself, then we can start to relate to it. We can see, oh, this is an actual human story of suffering. This is a woman who went to the clinic, who was, and I've heard these stories, I'm sure many of you have as well, who was abused or suffered violence at the hands of a healthcare practitioner. This is a trans person who was left to bleed in the street because emergency care realized that they were transgender. Whatever it is, once you hear that story, then you dismantle the cognitive dissonance. We start to break this concept of the us and the them, because that is the tool that we use to marginalize and disenfranchise people. We say that they're different to us. And the best way to dismantle that cognitive dissonance, I think, is through the stories. And those stories must go hand in hand with the policy. So we need to do the policy work. We need to have spokespeople from these organizations, or rather from these communities, sharing their stories, telling us about their experiences. And we need to start developing people in marginalized communities to start taking up those roles and to put them in the positions of decision-making and leadership. That's how we will empower communities. That's how we will achieve UHC.
Renee, your mic is off, please.
That's an excellent statement, and I think I'm just looking through some of the comments, and many of you commenting in from different parts indeed of the world, and the distinction that is being made between equality and equitability. That putting everyone on the same platform does not necessarily make them have the same access. That we must have systems that are flexible and understand the various starting points that we are all at. I think, let me just see really quickly, looking at the commentary from Ryle, I think it was, and from Dr. Kamal. Very quickly, Dr. Suzanne, there's something that is the big elephant in this room, which is, of course, the failure at global levels and the devastating effects that reverberate through health systems at all levels, whether it is failures that relate to accessibility, or indeed where there is failures in drugs themselves, or the access for universal healthcare to everyone. The effect on huge tracts of the population reverberates not only in the time when the failure has been observed, but very often in generations to come. In the increasingly large network of actors who are operating in the global health space, including organizations such as the one that you represent, how do we pin down who is accountable to whom, for what, and what the reparations should be in terms of drugs and vaccines, effects, and access?
Thank you very much, Renee. I'm just repeating what I understood from the question, because there were some breakouts. So overall, the question was about failures as global levels and how they have a destructive effect that literally reverberates through health systems at all levels. And we got the example of accessibility, but then it faded a bit. But I think I still can respond to your question in terms of
accessibility and effects.
And effects. Okay, and I just fully understood the question on who in that increasingly large network is actually accountable, or who, to whom and for what should we reach out when we talk about access to medicines or vaccines. So overall, Renee, you know, I think in the past, over the last years, there was so much time spent on identifying who should fix what. And I believe at the end of the day, everyone needs to contribute. It cannot just, and we see that also during the pandemic, and I think it's one of the key lessons we can all learn and share, that the big health problems are literally too big to be solved by one actor alone. So it's now the big question, how can we synchronize our efforts? How can we drive synergies between our efforts across the industry and the health sector, under the leadership of the government, to drive impact? So rather than saying there is just one accountable actor for a certain activity, what we see is that it's rather one health challenge for the entire population and all the different actors across the sector. And I believe if we start to not just holding one group of stakeholders accountable, but looking at it as a joint challenge and an opportunity to actually make a difference for the next generations to come, then we can start moving ahead. And maybe I'm overly optimistic, but when we look at partnerships and consortia that we have seen also during the pandemic, before around cancer care, we see very good examples that drive impact and that show impact, where we literally make a huge difference for patients. And I believe we need to further, so to say, capitalize on that, meaning building on that, because we have now a window of opportunity before everyone is falling back to that was our old pattern of working, and literally take the chance to work in the non-traditional partnerships that we learned during the pandemic. So now you're back, Renee, and I'm at the end of my response. Should I rephrase, or how do we deal with that?
No, indeed. It was only the photo that was off, but fear not, I have heard you right the way through, and I understand the shared responsibility statement that you have made. And I think even as our time closes, and it's the engagement on both chat and the Q&A is so very powerful. Thank you so much to everyone who is following this conversation. Masare, I want to come to you with a question that is coming in on the chat from one of those who are following, perhaps even by way of a place where we can pause this conversation, because I know it will be an ongoing conversation for a long time. From where you are, of course, there's the issue of data and data collection. And both the data collection and data use appears to be a challenge on this continent that may in some way perhaps need revisiting. How do we collect data and disseminate that data, share that data amongst the different players in ways that allow us not just to deal with the issues that assail our universal, predict and prepare for it on this continent? I'm just checking if there's a challenge with my sound, Masare, if you've heard the question.
I heard part of the question, and so I'll try to answer the part that I heard, and how can we do better at collecting data and sharing the data. I think, first of all, in terms of the data that are collected, a lot of times it's driven by the funders that are supporting the health interventions. And so we as Africans ourselves need to be involved in designing the data collection tools and how the data and what data needs to be collected. We need to determine what needs to be measured and how it serves our own purposes in terms of holding governments accountable and ensuring that we're progressing in the direction that we want to move in. And now there are so many ways to collect data. I mean, there's no excuse. We have tablets, we have mobile phones, we have internet technology that reaches far remote villages, reaches out to communities. So there's a very easy way to collect data, or we have developed many ways to be able to GPS locate areas and use the data. I think the problem that we may have the data, but we're not doing such a good job at analyzing the data and analyzing it in a way that we can explain it to non-scientists and we can explain it to governments. And so they understand that investing in health, investing in your populations is actually going to make you more prosperous. And we have to find a way to translate the data in such a way that it's understandable to finance people, it's understandable to governments, it's understandable to people who are not scientists, and they realize that we're not just talking about, we're talking about the prosperity of a country, we're talking about its wealth overall. Investing in health is an investment that has a good return for the country.
Indeed, I love that your statement is inclusive, and how can we include more in the delivery of universal who themselves are stakeholders, and ultimately to include entire populations in there rather than a solution provider, as you can very well tell, ladies and gentlemen. And also the chat is just so full of statements and queries that are very thought-provoking. I want to thank each of the panelists for the invigorating, certainly, and the very challenging conversation. I wish now to move to the closing remarks by the Honourable Ms. Mary-Rose Queenie-Effa, who is the President of the African Parliamentary Forum on Population and Development. The Honourable Mary-Rose, welcome.
Oh, sorry. I said that, thank you to giving me the floor. It will be very hard for me because of the connection, but I'm not sure that I hear everything you say. But let me do it in French. So, je voulais commencer par remercier tous les participants, toutes celles qui ont fait les présentations. C'était très intéressant. Cette session est vraiment une session qui me tient à cœur et qui dénote un peu qui démontre à souhait notre responsabilité à tous. Nous sommes à un moment vraiment critique de l'histoire de notre continent et pour dire du monde. Hein, et les crises, nous passons de crise en crise. Nous sommes confrontés à la pandémie, la plus dévastatrice que le monde a vue depuis plus de 100 ans. Encore ces temps difficiles rendent notre collaboration et notre responsabilité conjointe toujours plus vitale. Cette discussion a mis en évidence un fait très important. En effet, la CUC est fondamentale pour l'éradication de la pauvreté sous toutes ses formes et ses dimensions. Nous avons entendu, par exemple,
Renee, it seems that we have lost the Honourable Marie-Rose, perhaps.
Honourable muted. Kindly unmute.
M'entendez-vous?
Oui, maintenant nous entendons.
Allô? Allô? Allô?
We can hear you now.
You can hear me. OK. Donc, je disais, si vous m'entendez, c'est très bien. OK. So, je disais, le docteur René, par exemple, le paradoxe de ceux qui ont un accent écrasant à la richesse et qui n'ont pas accès à la santé est intimidant. On a l'impression qu'il y a deux santés, il y a la santé pour les riches et la santé pour les pauvres. Le moment est revenu de redresser les torts et nous devons lutter contre cette injustice sociale. Dr Anastasia a clairement souligné l'importance du droit à la santé, et cela est indépendant du sexe, de la religion, de la race. En effet, le droit à la santé est une pierre angulaire pour le développement et essentiel à la compréhension et à la dignité de tous. Nous avons entendu le docteur Esther dire que le mécanisme de la société civile sur la santé sexuelle, la santé universelle, la couverture santé universelle, fait beaucoup suivre les 83 engagements qui ont été pris dans la déclaration politique de la CUC. Je dois ajouter que la déclaration politique guide toutes les parties prenantes et la clé ici est d'assurer les responsabilités mutuelles et soutenues par tout l'écosystème. Hello? Hello?
On vous entend.
Allô?
On vous entend.
le docteur Suzanne a été très clair sur le rôle des produits pharmaceutiques et sur ce que fait Takeda pour garantir l'accès des soins de qualité. Il est essentiel d'accélérer l'accès à des diagnostics et à des thérapies abordables. Pour surmonter les défis mondiaux, il faut une responsabilité totale. Nous devons déterminer qui est responsable de qui. Nous devons mettre ensemble les partenaires pour un service de santé rentable et accélérer le processus de la couverture santé pour nos pays. Il y a le rôle de la société civile, la voix de la société civile qui doit être entendue. J'ai entendu parler aussi de mettre un peu tout le monde ensemble et surtout d'éviter ce paradoxe des riches et puis de rendre responsables nos gouvernants. Ils doivent rendre compte. Alors, il faut mutualiser tous ces efforts et synchroniser tous nos efforts. Un travail d'analyse, de collecte de données qui est très important et qui ne se fait pas. Donc, c'est un peu ce que j'ai retenu. Il y a beaucoup, c'est un peu ce que j'ai retenu globalement. La responsabilité, la bonne gouvernance, la mutualisation, la santé pour tous, sans distinction de sexe, de race, de religion. Et en conclusion, permettez-moi de dire que 3 déclarations marquantes en faveur de la couverture santé universelle ont été prises en 2019. En septembre 2019, la déclaration politique sur la couverture santé qui a été adoptée lors d'une réunion spéciale des chefs d'État et des gouvernements reconnaît que la couverture santé universelle est essentielle pour atteindre les 17 objectifs de développement rural durable ODD. En octobre 2019, 1800 parlementaires se sont réunis à la 141e Assemblée de l'UIP et se sont engagés à prendre toutes les mesures juridiques et politiques pour atteindre la couverture santé universelle d'ici 2030. En novembre 2019, 300 parlementaires faisaient partie des 15 000 délégués qui ont adopté la déclaration de Nairobi sur la CIPD pour parvenir à l'accès universel à la santé et aux droits sexuels et reproductifs dans le cadre de la couverture santé universelle. Cela démontre que l'engagement politique est nécessaire à la réalisation de la couverture santé, en particulier pour relever les défis du financement. Les parlementaires jouent un rôle clé dans la création d'un environnement propice, le renforcement des partenariats et le maintien de l'élan à tous les niveaux pour la réalisation de la couverture santé. Parce que les parlementaires, ce sont eux qui sont aussi là pour le vote du budget, ce sont eux qui défendent aussi les lois, ce sont eux qui sont là, qui sont supposés être là pour protéger les populations, afin qu'on ait, je ne dirais pas pourquoi pas une équité pour des questions de santé. D'accord, parce qu'on se rend compte qu'il y a deux santé, il y a une santé pour riches et une santé pour pauvres. Les pauvres se retournent vers les herbes dans nos pays et les riches vont en évacuation sanitaire ailleurs. Tout cela, les parlementaires jouent un rôle vraiment important. Ils sont le socle et ils peuvent faire quelque chose, bien sûr pas eux seuls, mais avec les ONG, avec les organismes internationaux, avec la société civile. Si on peut tous parler d'une seule et même voix pour que nous puissions avancer et rendre compte et bénéficier de nos droits. C'est un droit humain, la santé est un droit humain. Au nom du Forum des parlementaires africains, je tiens à dire que la déclaration politique sur la couverture santé universelle nous a donné un plan clair pour la responsabilité politique, y compris les recommandations et les conseils sur le leadership politique stratégique et la responsabilité budgétaire. Notre succès commun dépend de notre engagement à respecter les dispositions qui ont été prises dans cette forme. Merci beaucoup, merci à tous. J'espère que je n'ai pas été trop longue, mais j'ai essayé de ramasser ce que j'ai pu. Ce n'était pas évident, beaucoup de coupures.
No, thank you indeed. And I want to thank all of the panelists and indeed to all of the attendees for being here. Now, remember, after this, we're moving into parallel sessions. And I note all of the comments that this should be a whole day of conversation. I'm sure that the organizers are seeing this, but let this be a continuous conversation in the spaces where you go back to so that we can crack this. Once again, thank you very, very much. And back to you at the AHAIC organizing space. Thank you.
Thank you.
Thank you.